Dr. Hulvershorn, do we have a mental health system in Indiana? If not, at least can you tell us what the component parts might look like so that we can just get a level set sort of understanding? Some are in that system, others of us are not. What kind of shape does it take in Indiana?
Yeah, great question. I think before we talk about that system, I do think it's important to acknowledge that the work that was described this morning, like casseroles and faith communities and all of those things, are actually the foundation of what keeps society's mental health together. And I think the pandemic's been a really great illustration of when that isn't intact, what happens to us. That work is incredibly important, whether it's lead mitigation or you name it, all the things you guys are doing, that really is mainly what society needs. But occasionally people slip through where that's not enough, right? And so if you find someone in your life with a disorder, right, and that's the term we use clinically, like suffering with substance use disorder, mental health disorder that needs a treatment system, that's what we'll talk about now. So I just want to preface it though that that's not it. That's just a part of it, right? A small part, frankly. So slide, please. Let's see if this works. So when it comes, there's a little pyramid that I have, and I can just talk through it if we don't have it. But it's up, awesome. So my lens is that of a clinician. So I see people in the hospital or in our outpatient clinic, and along with a number of other clinicians in our state, when things have gotten really bad, right? So when there's been a suicide attempt, or there's concern that there could be, or that voices are being heard in one's head, those kind of things. That's when psychiatrists and other mental health clinicians come on board. So that system starts off with the pyramid. I think we could say prevention, right? So if I were a faith leader, I would be thinking about prevention approaches in addition to all the other awesome things with casseroles and the other great stuff you do. But there are a few things that have been studied in the field that do promote mental health, and so that's the base of the pyramid there. And again, those things can be helpful for everyone. So what comes to mind for me there would be things like mental health first aid training. So this is the kind of training that helps the general public understand, what is bipolar disorder, what is schizophrenia, what is depression. I mean, I remember in my life when I think about different events before I went to medical school, I'm like, oh, that person had bipolar disorder. I didn't know what it was at the time, but that's what was going on there, or that was alcoholism, et cetera. And so most of us would, I've had the privilege of going through training. Now I know what those things are, but how would you if you don't have that luxury? So there is a curriculum that's designed to just train everybody on kind of the basics of mental health, and it's evidence-based, and there are people that can do it. And so I think the more people that are, have the experience of being around something like that, the better, right? The more we know about it. I also think of things like social emotional learning programs for children in schools. Just help all of us, if we think about, my parents' generation, even my generation, we didn't learn about what feelings were in kindergarten, but boy, my kids, they know. My kids manipulate me with this because they know I'm a psychiatrist. I'm like, Mom, I'm feeling anxious about this. And I'm like, okay. Because they know I'll be like, oh, you're feeling something? Let's talk about it. But anyway, kids these days are much more articulate about these things, and that's really important. Also, I think of parenting interventions, and certainly there are treatment interventions, but there's also tons of research that if you invest a little bit of money on teaching people how to really use very adaptive parenting skills, that pays off big time for the society. So, how to not invalidate your children, how to listen to them, all these kinds of things. It's not intuitive. I mean, and some people kind of know how to do this, but a lot of people don't, and it's a very small investment that pays off big time. So I think things like that are really important in the prevention landscape. But if we think about treatment, so somebody's, your neighbor's not feeling well and you're really worried about them, then we enter into the treatment landscape where I used to have outpatient treatment as the second thing up on the pyramid, but what Jay was alluding to is we really have an enormous shortage. And so what we've been thinking about are innovations and how we can stretch the resources that we have to work better. And so one of the things that we've done at Riley And this is based on, actually originally came out of Massachusetts, but most states now have programs like this. Instead of the pediatrician or the family practice doc calling the psychiatry office and saying, hey, can you see my patient now? Because the answer is unfortunately no. Most of the time we have a 2,000 person waiting list or whatever. It's no, I can't see your patient, but can you talk to me for 5 minutes about them, and I might be able to help you. So this model is called, these are called access programs, and so we have one for the state. So any practitioner who's trying to care for a child in the state of Indiana can call a number and get a child psychiatrist from Riley on the phone, and we'll talk you through it. And you can call us every day if you want. We love it, and we've had, I think, 1,400 calls so far. And what we've found is that we've been able to train pediatricians. Hey, you don't need me to treat depression. I can teach you how to do it, and so you can treat all your patients for the rest of time. So it's this wonderful multiplier of knowledge. And so that's one of many kinds of consultation ideas that are really very popular and very exciting in the field of mental health right now. That you don't need to sit for me to have my time for 2 hours to evaluate you. I could teach a pediatrician how to do this, and they could treat thousands of kids across their career. So that's one idea. But let's say somebody really is not appropriate for a consultation, that pediatrician has tried everything, or that family medicine doc, or whoever it is, they've done everything they can. Then it's time for outpatient services, right? So this is somebody walking in the door for maybe an hour a week for therapy, maybe once a month with a psychiatrist, but they live in their home. And this is the best treatment. If we can keep people at this level of care, that's great, because they can go to work, they can they can and live in some ways, like live in the environment, the stresses that they need to learn to adapt to. It's not an artificial environment, it's their real home. They get all the supports from their church and their friends and whatever else they're doing while they're in this kind of treatment. But sometimes that's not enough, right? So you've tried that, and that wasn't adequate. So again, you see the pyramid getting smaller as you go up, because fewer and fewer people need these resources. So most people do great with outpatient care, especially if they can get evidence-based, high quality outpatient care. They don't need more, but some people do, a small percentage do. And so in that case, intensive outpatient care is the next level up, where that's several hours at a time, multiple days a week, maybe 9 hours a week. So that's a lot more intense, right? So that's maybe after school, after work, in the evening, 3 times a week, getting therapy, getting medication treatment, getting group, getting peer recovery coaching, you name it, all sorts of things bundled into that service array for both mental health and substance use disorders. And then above that, partial hospitalization. So at that point, the clinicians around you are concerned about your safety, probably. So they're okay with you going home at night to sleep, but during the day, maybe not a good idea to be at school or work, because the symptoms are really prominent. And so those insurance companies are really interested in who's getting that care, right? Because it's pretty expensive. And so you have to demonstrate that there's really a need for this level of care and all of those above this, well, frankly, all of them. But so that's a person who's going every day to the treatment program in the morning, getting dropped off, spending the whole day getting therapy, getting medication adjustments, getting, art therapy, music therapy, you name it, throughout the day. But clinicians in their lives feel comfortable that they could safely go home at night. And it's a nice way to transition from other levels of care. But let's say partial hospitalization is not enough, because we're eminently worried about someone's safety. That's inpatient care. So that's the next level up. So I think I'll hear people say, well, I'm just going to go check myself in. And I'm like, well, you can't really check yourself in. We decide if you're appropriate, and the insurance companies, frankly, decide if you're appropriate, because this is very high level care. The door is locked. You're not wearing your own clothes. You have no cell phone allowed. We're really worried you're going to kill yourself, right? Or that you might kill someone else, or harm yourself, or you're so unable to function that you're not eating, you're not drinking, you're very ill, right? So that's what inpatient care is, and we don't have enough of it, and they're very precious resources, so we have to restrict access to it to save it for those people that truly need it in those moments. And there are inpatient levels of care for substance use disorders, for mental health, for adults, for adolescents, for kids. And so that's that very high level of care when things really are quite unsafe, and that's the key feature there. And then sometimes people are hospitalized in an inpatient setting multiple times, and we're still not seeing the gains that they need to make. And so then we're talking about residential care. So inpatient stays are usually 5 to 7 days long on average nowadays. If that's not enough, and that you've tried that multiple times, for children and for substance use disorders, we have residential programming. Indiana does not have a waiver, and there are federal prohibitions against using Medicaid dollars for adult residential care, so that doesn't really exist in the state. But if someone needs to go somewhere for 6 weeks, for example, 8 weeks, 10 weeks, really a lot of treatment, a lot of, like, let's remove them from the environment where things are not going well, that's residential care. Again, a very small percentage of people that need inpatient care would need residential, but it is there. And then the very highest, most intensive level of service are what are called state hospitals, and you'll meet Jay Chowdhury later today. He's the director of the Division of Mental Health and Addiction, and that agency oversees the state hospitals. So you might, the word asylum is kind of an older term that might have been used for these places where people might go for a long time, but these are folks who maybe have very chronic schizophrenia, and every treatment's been tried, lots of different hospitalizations, and still no luck, so they need just more intensive care. But a very small percentage of the folks in the continuum need that high level of care. So that's really the system as I think about it in terms of levels of care. But next, one really quick point here, there's another system that, you could go to the next slide, please, that is actually the way it looks when you're a person in the community trying to figure out what to do, and that's very confusing and complicated, and frankly determined by economic factors, right? So when people, like literally every day, someone either in my family or friends or somewhere says, can I talk to you about someone, I need a recommendation for treatment, and my first question is always, well, do they have private insurance, they have Medicaid, or do they have cash? And I hate that I have to ask that question, and we're not asking that question for orthopedic surgery or for oncology or anything else. We're not having that meeting about that, right? Because it's a financially viable mechanism through normal, traditional Medicaid and insurance. But mental health has all kinds of economic factors around it that make it not sustainable for medical providers or for other systems without some kind of subsidy. And so what that means is there's a big shortage of providers. And so a number of folks sort of have capitalized on that and now have private practice. So literally yesterday, my call was, can you pay cash? Because if you can, I bet you could get in this month. If you can't, and here's the names of people. If you can't, well, get in line, because there's just not enough resources for those that want to use their own health insurance, which is ridiculous that you would have health insurance but still pay cash to get care, but that's the universe we live in, right? And then, God forbid, we're talking about Medicaid. That's a much different pool of resources. So these are just some examples of places where you'd go. So CMHCs, that stands for Community Mental Health Centers. That's a program that was federally set up in the 1960s to help states have a system of care for mental health. And actually, it wasn't designed for low-income folks at the time. It was designed for everybody, but over time it has morphed into kind of a safety net service provider network. So in Indianapolis, some examples of community mental health centers: Sandra Eskenazi, Adult and Child, there's a bunch of them. Hamilton Center, Indianapolis has a lot because it's a big city, but each area of the state has one of these entities, and then you can go to private practices, healthcare systems, provide mental health care. It's a complicated system, and a lot of it depends on your payer source when you step into it, unfortunately. So that's why it's so confusing and difficult for people to figure out what they need. It's not like any other part of healthcare.
Fascinating, thank you. That was really, really good. Lindsay, where do we sign up for the academic credit that we get for taking good notes? That was really helpful, and it's so tempting to dive in because we need to understand it better and wrestle with it as we think about improvement, but we have so much more to cover that we're going to have to hold it there for a moment. But think about it with your follow-up questions that we'll have some time for at the end. I think you're probably familiar with the lists that come out now and again about the most watched TV programs. That's some old school language, I guess, but typically it's like 18 or 19 of them are NFL football games. Those are our most watched programs. So to be running one of those operations where the world's watching you, and for you to say, but here's what we care about, super powerful. And for some reason, you've selected this theme, indeed, this particular issue of stigma as the thing, Kalen, you personally are bringing leadership to, but the family is getting behind as well. Why?
I think. Can you hear me? Well, first I just want to say thanks for having me. I'm excited to be here in person. It's been a long time, I feel like, since I've been in a space like this, and I think little things like that speak to the work that you guys do and just the feeling of feeling normal. And I think what you guys bring to communities is part of that. And, you know, I think we see that in running our organization and getting people back in the building and how difficult it's been. And I wanted to say that, because I always say this and I always embarrass Leslie, is that she's become one of my heroes. So it's so nice to hear everybody clap, because every time she talks, I can just listen forever. And I always start out with, anytime I speak to Kicking the Stigma and our campaign and our work with mental health, that I am by no means expert. You know, we are not. And I think people come to us now because of our involvement in this, expecting us to be, and we really lean on people like Leslie, and I haven't gotten to know Erin and Linda as much, but people like them that really are in the trenches and have been for a while. And I've done my best to do a crash course of trying to understand the system myself and where we can place, you know, our stamp of approval, if you will, not just with dollars, but with intention to get other people to pay attention and to learn and to see that this is a problem and that this is something you should care about, and here's why. And I think Leslie will tell you, like, anytime, or even Jay Chaudhry, who you'll hear later, they'll tell me things and I'm so upset. I can't believe I didn't know that. You know, I'm born and raised here in Indianapolis and very prideful Hoosier. I went to Indiana University. Sorry. I guess you went to both, though. And I, you know, am very prideful of my state and what we do. And I think the work that we do is always intentional and trying to show up and make this not just be a football team, but we have seen what we've been able to bring to this city and to this state since we came here in the 80s, and how different it was when we came and how different it is now. And we like to think that we had something to do with that, especially in the community. And that's really part of our backbone. You know, we're not just a football team. And, you know, my dad always says we're stewards in this life. You know, owner is our title, but that doesn't really mean anything. We're here for while we're here, and how can we leave this place better than when we came in. And so that's really all we're trying to do. But when it comes to this specific initiative with Kicking the Stigma, I guess I should tell everyone in the room, just for a background, that yes, I am owner and I'm involved in a lot of general operations, but my main leadership role within the team is overseeing our giving strategy and our philanthropic decisions, and really kind of why we give to where we give. And we've really tried to be more strategic in the last few years, and I think my older sister kind of challenged me, like, we've never had something that was ours. You know, if we were to sit down and pick something that meant something to our family, what would that be? And mental health, we've had a history in our family of mental health challenges, and we know directly what it feels like to feel like you want to hide that from the world and from the fear of shame or judgment, especially double time, I guess, living in the limelight slightly as well, and what comes with that. And so we knew what it was like, not just for us, but all of our friends that we've been helping over the years get into different institutions because they can't find a place, or they're on a waiting list, or there's nowhere here in Indiana. And so the list goes on as to why it's important to us. But when we started to dig into the numbers, it was just prior to the pandemic, ironically, and it was specifically numbers in the state of Indiana, and they were depressing and upsetting and shocking. And that really solidified it for us. Was, one, how do we not know that this was such an issue when we're so closely tied to it ourselves? And how, this is, you know, inexcusable in our minds. You know, this, like Leslie said many times, it shouldn't be this way. And so the pandemic hit, and as we all know, it has made this issue much more at the forefront and even more important than before. And we got going, you know, within the pandemic. We used My Cause, My Cleats program, where players, you know, put a cause on their shoes. We decided to make our own and have that be a way to announce what we were doing, along with a $3 million gift, a couple million to different hospitals, and one specific recovery center. And that's kind of how we kicked off what we were doing, to kind of say, we're doing this, and this is going to be something that's a long-standing initiative of ours, which led into, our first virtual fundraising event, which was a week long, and we raised a little over $2.4 million, and then my dad matched that to be a little bit over 4.5. But to date, we have committed through that, and then our own dollars and our PSA buys, et cetera, a little over $16 million in the last 2.5 years. Wow. And I would say we're not stopping there. And I think that's one of the big things about this, is that I think a lot of times people do initiatives and campaigns, and you see these big splashy things, and they go away. And for us, this is something that is long-term and isn't going away. And we're already planning our next PSA for the fall. We have a fundraising event that we hope to announce in the spring that will be in September. And it's not just, it's such a multifaceted campaign and initiative for us. It's obviously it all began with stigma, because when we started to talk to people in this field just to understand and wrap our head around it, stigma kept being the thing that comes up as the biggest roadblock at the start of it all. So before that pyramid exists, that's all over that. Like anywhere in this topic, that's the start. And so we knew we wanted to affect change in that space, kind of normalize these conversations. And I think, events like this, and we're trying to be proactive and being a part, we're creating more conversations like this. And for example, I'll just use for our campaign initiative, we have a lot of videos from, anyone from Snoop Dogg to, ex-players of ours or ex-coaches like Tony Dungy, talking about why this is important. And the point is not just, they might all be saying something similar, but to someone watching it, that made a connection to them. And that's part of the point of the, PSAs. And, we weren't even asking anyone to do anything in the PSA. It was literally just saying, let's talk about how this is an issue. And I think my dad is to credit in that sense, because it was supposed to be more of a local-based campaign, kind of. And he was like, no, this is too important. It needs to be national. It needs to be a bigger conversation. And so a lot of the work we're doing, we hope to be, encouraging other teams and other sport organizations, or anyone who has a platform of some kind, to use it in this way for good, and to shine a light on this area that has, been in the dark for far too long.
So good. I cannot imagine, besides the NFL and athletics and entertainment more broadly, who influences culture more. And if we're going to change culture, we're not going to pass legislation to do that or do that through a grant. We're going to do it through influence and inspiration. And nobody could be doing it better than you guys are doing it. And it's fun to watch other games and to see your PSAs come up and the league embracing it. So stay tuned. So much more to come. And the Kicking the Stigma Action Fund, I think is what you call it.
Yes, so I guess there's so many parts. And you can find all of the information on Colts.com/KTS. Standing for Kicking the Stigma, to see, all the videos I'm talking about, all the success we've had, all the plans for the future. Or we've also been, and actually recently I was just talking to Leslie, we do get asked a lot of questions of, we have so many people, fans to people within our building, who are like, my son needs help, my wife needs help, my friend needs help, what do I do, where do I go? And we found ourselves being like, I don't know. Like, usually, because honestly, the people that we've sent to inpatient places, friends of ours that we've paid for because they can't afford it, or cash gets them in the door, are a lot of times out of the state. And I think, so it's been a learning experience for us too, and trying to understand how to suggest things to people. So on our website too, we have, certain places that we trust, whether it be NAMI or MHA, or places that have good guides, or areas in your local area to go find help or figure out what you need. And one of the bigger things, and I know we'll get to it later, so I don't want to jump ahead, but is youth and how to help parents and kids themselves, or even educators, or any kind of caregiver, understand where is a good place to go. Because there is so much information out there. I think self-help and all these things, and all great. But in terms of, when you get higher up the pyramid, how do you know when you're higher up the pyramid? You know, how do you know that next step is needed? And Leslie sent like so many resources that I've been, you know, gobbling up this week and trying to digest myself. And they've been so helpful. And I have a 2 and a 4-year-old, and you know, I'm thinking of these things for myself. And so it's things like that that we're trying to also have on the website for people to see. But that's where you can kind of find all of the information.
Yeah, thank you. We'll come back to both of you on the children and youth issue in a minute. But Aaron, you have a powerful personal story here, along with Janelle, and so I'd like to start. We want to get into a neighborhood, so we're eager to have you tell us what it looks like in Southeast Fort Wayne. But maybe you could start telling us your why. You had a lot of options in your career, and you had a lot of options in where you wanted to live, and you selected this issue in your hometown. So maybe you could explain why that, and then maybe tell us a little bit about what it looks like serving your neighbors.
Certainly. First and foremost, I want to echo what Kalen said, and thank you all for allowing me to serve you all and be on this panel and welcoming me to Indianapolis from Fort Wayne. It is such an honor to be speaking here. A little bit about our why is we simply exist to fill a gap and create a bridge between the systems that you're talking about, right? The systems of the nonprofits, the private sectors, the community hospitals, with the people that they serve and that they're targeting, the communities, right? Because as Jay mentioned, we're embedded directly in our community not because of the reach, but because we are the community. We are the people who were born and raised in our underserved, impoverished community, and we understand, we speak the language, right? We look like, talk like, and live through the same barriers and systemic issues with the people. So that's our responsibility, right? We often talk about how many times when we're sitting around tables, because we come from corporate America, we worked for large healthcare systems, we worked in the schools, we worked in homeless shelters, we worked and sat at a lot of tables and been a part of many conversations, right? And hearing about what the community needs and what the priorities should be. But oftentimes what happens is when we're sitting around those tables, the priorities of those individuals don't match the priorities of the community. So we're talking about priorities within the priorities, right? So for us, our existence is we've sat at that table long enough, but we've also been in the barbershops and in the community grocery stores and sitting on the block, if you will, on the porches and hearing from people about how the systems are impacting them, right? And they often don't have a voice or an opportunity to sit at those tables to tell the story. So for us, how can we be those individuals? How can we be translators, right? How can we go from sitting at the corporate table to the community barbershop? How can we go from the barbershop to taking that voice and advocate back at the table, right? And oftentimes when individuals like ourselves get these seats at the table, it's often that we feel like we have to conform to our counterparts, right? Because of we often don't feel like we deserve to be at the table, let's be honest, right? But the reality is we do, but we can't forget what our responsibility is. Our responsibility is to our constituents in our communities. It's not to conform to the voices and the people, the funders, right? We have to do what the people need. So that's our why. That's to bridge the gap, to be the bridge between the systems. Our facility, as mentioned, located in Southeast Fort Wayne, is located directly in the neighborhood of the people that need it most, which is the most vulnerable, marginalized community in Fort Wayne, which is Southeast Fort Wayne. And we were placed there, one, because obviously we're from there and it's our community and we're passionate about it. But also we wanted to disrupt the system. And I use that word intentionally. Because a lot of times, again, the barriers that people face are the payer mix, right? The insurance and can they afford to self-pay and all those things are a barrier. Because a lot of individuals don't go to mental health counseling, yes, because of the stigma, and we do a lot of work around representing healing, but also because they can't afford to self-pay. But also, and a lot of them do have private insurance, But the stigma around insurance, as you mentioned, some people don't want to use their insurance is because it then shows up on their medical records. And guess what? That's a no-no for a lot of people, right? They don't want diagnoses following them, right? Because a lot of our counterparts, so when I'm making these references, I'm talking about the BIPOC community, Black, Indigenous, people of color, right? We unintentionally provide culturally centered mental health. We serve anyone, but we unintentionally, to fill that gap and be that bridge, have a focus area on the BIPOC, Black, Indigenous, people of color, right? So that barrier of not wanting things to show up on their medical records and insurance, it's real, and they don't have the dollars to self-pay, because a lot of our counterparts, and we know this to be true because we have a lot of white clients, they self-pay. And the reason they self-pay is for that reason. But then we have the barrier of individuals not having the funds to self-pay and pay hundreds of dollars for mental health services. So for us, as we sit in our strategy meetings and we're talking and we're processing, how do we create an organization that is a part of the system because we're a nonprofit, but not feel like the system? That's hard to do, right? Because you have to create a sustainable business. You have to pay your therapist well, but then you also have to cater to the needs of the people. Because in all honesty, we don't take Medicaid, and we don't take Medicaid because that feels like an extension or a part of the system, right? We don't take DCS referrals currently, not because we don't see the value in it, but also because a lot of times when DCS comes knocking at your door, that's part of the system, right? And that means you're here to take something from me or to harm me or to put a barrier around me. And when you come to a mental health facility mandated through DCS or through referral, you don't want to be there, right? You're doing it because they're telling you you need to do it, right? And we understand those people need to be served, but how can we create opportunities for individuals to walk into our space and bring them whole selves because they want to be there, right? So we've done things like sliding fee scales to meet people where they are and do all those things, and we're working through strategy and trying to figure out what that looks like, again, to be that bridge, because we do understand the system. We understand why the system operates the way it does. We understand the funding avenues and funding streams, and we're, again, intentionally having the tough conversations that are needed, right? Because our why and our ultimate goal is to represent what healing looks like and feels like for people. And this is what we show up as, right? Because we are trying to meet people where they are, in the thick of who they are, and we want people to know that you belong, you're welcome, and we're here for you, right? Our center was created for you, with you in mind, right? Something as little as this, and I'll point this out just because I'm sitting up here in my Jordans and my hoodie and so forth, right? And many of you are probably like, wow, right? But for me, this is authentically who I am. This is me, right? And when people walk through our doors, they're coming in authentically who they are. And something as little as my dress can be a barrier. It could be a power differential, right? They already have this doubt in their head and this resistance to even walk through the doors. So when they walk through our doors, I don't want to further that resistance or that stigma with mental health, right? A lot of my conversations with the people I serve, a lot of young men, it starts with talking about our sneakers, our shoe. Right then and there, I've lowered this wall, right, that they came in with because they relate to me, they see me, I see them. We're now talking about sneakers because we're in the sneakers, and then that leads into deeper conversations, right? So for us, it's always very strategic on how can we, again, not feel like a system, but still be a part of the system because we have to be, right? And how can we be that bridge? So that's that's our why, and that's why we exist. We didn't set out to necessarily be entrepreneurs, but this thing came knocking on our doors. We were in corporate America comfortable. We were making great money. We had stability and benefits and taking care of our little ones. Right? And it was scary, and we was doing this on the side. So my background is in social work. My wife, who Jay mentioned, Janelle, who you will hear from later on the panel, and during our breakout session, she's a licensed mental health counselor. So for us, we were doing this stuff on the side and serving where we could. And then when COVID happened, when George Floyd happened, our phone started ringing off the hook, and it went from, us pursuing it when we wanted to it fully pursuing us and engulfing us. And as believers, it was time to step up and be obedient to what God was calling us to.
Yeah.
So again, for us, it was one of those things where we had to, and you sung that song so beautifully, we had to rise up, right? We had to rise up and answer the call. And it's been tough because, again, we're doing things a lot different than what other entities and organizations have. We've been in existence since 2014. However, we transitioned to a nonprofit to meet people where they are in 2019. So people view us as an organization who's in its infancy, and from a structure and strategy standpoint, we're building. So it may seem like we're infancy, but we've been doing this work for years. We've been in the community, we know our people, and we know what they need, right? But knowing what they need doesn't always make it easy to give them what they need, if that makes sense. Because we have to understand, the system that we're in. And how do we then capitalize over here in these resources in order to meet the people where they are, to give them what they need.
Well, that's beautiful and powerful, and I'm so glad that you both said yes. I'm really grateful that you're a dual citizen and that you live in the world of the establishment and the professional systems and in the grassroots. Your voice needs to be heard, and so we're going to continue to put this mic in front of you and seek your counsel as we move forward. So thank you for that. It also struck me as you were talking that you're reducing the barrier of another type of stigma. So we started the panel thinking about personal shame and just the difficulty of being seen. When Darius Leonard puts that T-shirt on and says it's okay to not be okay, we're starting to address that. But stigma in systems, or power structures, is another one, and you're beating that down. So thank you.
Thank you.
Linda, can you tell us about your personal passion in this work, and NAMI? Those on the inside know all about you, but that may not be the majority. A lot of us are coming in more as lay people. So could you tell us about the good work that NAMI does as well?
Absolutely. So thank you so much for having me here and giving me this opportunity. NAMI stands for the National Alliance on Mental Illness, and I'm very passionate about this work. Like many of you, I also have mental illness in my family, and so it's touched me very deeply. And NAMI's also touched me very deeply at a time when I needed them, and so it's been really important for me. NAMI has so many programs that are peer-led, so we offer something that's a little bit different than what you offer, Aaron, and what you offer, Dr. Hulvershorn. We don't have clinical care, but what we do offer is peer support services, and these programs are led by people that either have a mental illness themselves and are living in recovery, or a family member of someone that has someone in their family with a mental illness, and they can guide them through from the wisdom they've learned through their journey. And so I think it's so important for us to tell our stories. I think that's been a theme I've heard a lot today, but that's also something that NAMI does. We have programs that teach people how to tell their story effectively, which can break down barriers, and we have programs that are free to the community where we can come out and tell our stories and tell what that recovery journey looks like. So it doesn't seem so out there, like, oh, it just doesn't happen. It's not going to happen to me, or it's not going to happen to my family.
Yeah, thank you. Appreciate that. I want to come back and layer that story a little bit, but we teed up a couple issues that I want to get on the table, and I'm interested in seeing even how some of your partners are addressing a couple of these things, starting with the disproportionate impact that children and youth experience, which was a shocker as I got involved with the roundtable. And Kalen, you were the first one that enlightened me on how early this presents. And I'm sure for so many years it just was not understood. Now it's better understood. I don't know how well it's addressed, but maybe you could both, first, Dr. Hulvershorn, from a maybe clinical perspective to understand how youth are affected by this issue. Maybe, Kalen, you've also done a lot of research in here, your passion and your interest, maybe some of your early insights into the unique problems and maybe some of the solutions. We'll preview this afternoon's panel a little bit.
Yeah, so I think there are disorders that happen to hit in childhood. Autism, you know, ADHD. These are things that they're developmental disorders. You're sort of born with them, but they show their signs very early on. I mean, you can now diagnose autism at 6 months, you know, if you have the right tools. That's one category of issues. But I think what maybe you're talking about that was surprising news to you was that if you think about the disorders that traditionally we think about adults having, substance use disorders, schizophrenia, bipolar disorder, major depression, these disorders actually often have their onset, the first start of their symptoms in adolescence and even late childhood. So most people, if you ask them, you know, if they're, you know, 30, 40, 50 years old, and say, when did you first notice something was going on? They'll tell you, I was, you know, 11, 12. You know, nobody understood what it was, but there were signs then. So, so we certainly have disorders that are prominent in childhood that we've known about for a long time, but we have an opportunity as a field to really try to prevent and mitigate the effects of these typically adult psychiatric disorders that actually start really early on. And things like substance abuse prevention is enormously important. I think this is one area that people don't realize, you know, cannabis leads to psychosis, you know, current, you know, like not just in the moment, but long term, things like that. There's all sorts of things that we can do to help make this better for people throughout their adulthood, but all of it starts in adolescence. Also, the pandemic, and actually before the pandemic, there was this big concerning rise in suicide rates in youth. So for a long time, since the 90s, we've seen suicide rates going down, more treatments available, great, we're happy about that. And then people started to observe in kind of 2014, 2015, wait a minute, that curve is ticking up again, and it just keeps going. And so especially with young females, 14 to 16-year-olds in particular, is where the really concerning data is. We don't entirely understand this as a field because lots of things contribute to suicide rates, but a big hypothesis is that social media is just this whole new world for all of us, right? And it's really hard for especially young people. I know how I feel when I'm like, oh, I wasn't invited to that thing that the other moms went to, and luckily I'm like, I'm okay, I'll be fine. But imagine if I was 13 and that was like, I was forming my identity, and adolescents are social animals, right? That's their important part of their development. It's really impactful, and so we meaning the field, thinks that there is a big contributor of social media and how that can really isolate adolescents. So that's a big part of the story right now too.
So maybe just to follow up there, if you're master of the universe and you could fix some things.
I've asked her that literal question before.
Yeah. How would you proportion our need to understand things better about what's going on and what to do about it? Like, is it a supply problem on the other side, or is it we still don't even know what we're dealing with yet?
Yeah, I was just thinking about this the other day. I mean, I think the treatments that we have are pretty good. They work pretty well. To fix those treatments and make them better is enormously expensive. So luckily we have the NIH. There are some major organizations that are dedicated to psychiatric research, but to really make things better, that's incredibly expensive. So personally, I would say that's not really our job in the room. I mean, I do research, so it's a little bit of my job, but we can, that's part of the story. But I think a bigger a thing that we can more easily impact is getting the treatments that work out, getting more people trained in them, getting more access, because that will actually have an enormous effect, and we can do that. Like, it's a solvable problem. We just have to be organized and strategic and all of that. But that's where I think a local community really can make a big difference, personally.
Very good. How did you tune into how young this problem is, and where did some of your investigation lead you?
Well, like I said, anyone at the beginning of the campaign, and still, we get constant emails, calls, like, we want to connect with you, anywhere from a very small organization to a very large organization to national to local, and we really do our best to try to take as many as it seems to make sense and also be able to do our other parts of our job. And I think one of the things that sparked interest in me was seeing Nationwide Children's Hospital in Ohio opening up this brand new inpatient facility for youth, and talking about the numbers, and and then so it led me to them, because I, again, prideful Indiana girl, was like, well, why don't we have that? Like, that's not okay with me, and I know Riley's so amazing, and I know that, And then, of course, I learned that Riley did have an inpatient. It's not as big and all these things, and that's a whole nother story. But the point being, like, when I asked to talk to the leading person there, and I just learned a lot from that conversation in its own, meaning, well, this is completely privately funded. And it was a $50 million gift from, 50, not 15, from Big Lots, and along with this and this and this. And that led to the conversation of, well, because this just doesn't make hospitals money. And I said, what? I was like, okay, like, I don't understand. So then it led me down this road of like, well, of course I can't fix this on my own, but it made me very upset. And I think it's not something, you know, we've all talked about. That shouldn't be something that, especially with your kids. And it broke my heart. And I have the money, and I have all the resources in the world. And growing up with the issues we did in my family, I went to therapy at age 8 and on. And so it was normalized to me. But not just that, you know, that not only was I supported by my family and told it was okay, I had the money to go do it, and I had the access to do it, and I had, you know, we had everything under the sun, and it was still hard. And it's still hard. You know, I openly struggle with anxiety. I've talked about it a lot, and I always laugh. I'm like, and I still do. It's not something that goes away. And, you know, I was the kid in 5th grade who I had a specific room I had to go to with her, and then she'd have to leave me there crying, and no one, you know, I was in therapy, and it was still really hard for me. And I, you know, eventually learned what that meant for me and what that means for me moving forward. And I look at things obviously much differently because of my own experiences. And I think, so my own personal ties, and then I have a 2 and a 4-year-old, and I don't want the world to look the way it does. And, you know, I told Leslie, and I even told the lieutenant governor, I was like, we're letting our kids down. Like, then they're our future. We're expecting all of this, you know, expect all these things from educators or even police officers or all these things. It's like, but is that their role? Like, should we not be supporting other trainings or other facilitators? Or, you know, I've talked about this with MHA, and I just think it's so interesting to bring up with 998 rolling out, and I'm sure that'll be a discussion here if it hasn't already been. But looking into doing, instead of ENTs, and EPT, where you're literally trained in psychiatric, like, that's your role, and you can go into that from high school, and you don't have to, because again, you look at the stigma and access to resources also applies to the workforce development, especially in youth, but all over. And the fact that not everybody can afford to go to school for 8+ years and then pay off that debt and then not get paid well in the role that they're doing, and then expect, you know, you can't boil the ocean. Like, you have to try to find spots that you can affect and then build on that. And so that's really, if I was to describe like what I'm trying to do and like what we're trying to do with our initiative and our effect in this space, is that. And, you know, that's what led me to the youth part. And, you know, the numbers keep rising and the questions keep coming. And, you know, I am a young mom, and I talk to a lot of moms. And then on top of that, our players, you know, that's a big part of what they hear about is youth, and they see the effect in their communities, even when they go back home. And this, you know, multiple of them have their own foundations and see it within the families that they may be going to deliver bikes, but they end up talking about the mom or the kid's mental health issue that they had. And I always we had 4 main pillars, which was awareness, peer-to-peer workshops, because we have seen a lot of data on how that's such a successful, you don't have to necessarily always, again, go back to the pyramid, be in a therapy session to have an effect on a positive effect on your life. Equitable access to resources, and workforce development. But we knew always that youth was there. We just didn't know, we hadn't done enough research or seen where we wanted to put our money where our mouth is kind of thing yet, which led me to Leslie and kind of started the relationship there. But our biggest gift is with her and Riley and their Be Happy program. And what was most interesting to me about it, and I'll tell anybody who asks, because it's hard to find something like this, where it's a program where anyone can call them. There is no barrier or anything from a hospital network. Oh, well, you're with community and you can't call us because we can't do that. That's so hard to find. And so that was one of the biggest things that was interesting to me. And, you know, part of that, it's kind of funny. You would think we're like literally saying like, we have millions of dollars. Come and tell us what you like. You know, what you're doing. And that was also part of the learning experience of like, again, what's going on, small to big, like what are organizations we've never heard of before, community organizations that we aren't even aware that the work they're doing. But still, we're babies, like in infancy, like a lot of people don't know about our grant program yet, so we're doing our best to get that out there as well. So that the second cycle for us will open this summer, so I'll make sure that you guys see it. But so far, there's been like about $3 million distributed from that.
Wow.
But yeah,
That's
sorry,
awesome.
I realized I didn't finish that earlier.
That's
sorry.
awesome. Yeah, thank you for that. Boiling the Ocean came from John Lecklider. I didn't mention him earlier. So the roundtable is co-chaired by Suzanne Crouch, Lieutenant Governor, who's going to give her why story at 2 o'clock and to launch that panel. And John Lecklider, who said, when you're the CEO and chairman of Eli Lilly and Company, when you call, people pick up the phone. There's a lot of power in that job. No false humility there. He understood. And when he sought help for his senior leadership team and others that were struggling, he couldn't find answers either. That was part of his why. So when we think of the powerlessness that many of us feel in this issue, it goes up to the C-suite at Eli and Lilly. So we have Mike Smith, as I mentioned here earlier, spent some time in the insurance industry, is on Riley's board. John Lecklider. So government officials, the government has about $350 million in venture capital, one-time expenditures over the next 18 months that'll be deployed. The 988 system, which will allow so many more people, especially if we can reduce stigma, to seek help more easily. 2 state commissions, a behavioral health commission and a public health commission. So the landscape is changing dramatically here, and these are themes that will be picked up this afternoon. But all of that should strike us in this room as opportunity. So we have to be clear-minded about it and bold, and so all your remarks are pointing in that direction. Thank you in this campaign. But the fact that people aren't even coming for grants yet is just an indicator that the conversations just needs to be enlarged for sure.
Might read the list of recipients and actually look at because that's part of what we're trying to do. It's not just the money, it's also, Be Happy is a good example. This literally it was, social media can, in my mind, be the devil, but in some ways it can be beautiful. We announced our gift to them of, $650,000 to Be Happy program, and someone from the Pacers immediately saw it and read it and tweeted saying, I'm matching that. How did I know about this? This is an important issue. And it was in fact received. It was not just a statement. So things like that, trying to inspire conversations and more giving is really what we're trying to do, not just give money is really part of it too.
Yeah, for sure, very good. Steve Simon is Gen 2 or 3 with the Simon family. And he's, of course, they own the Pacers, and he's a member of the roundtable as well, so you can see we have quite a team. Aaron, you may want to keep with the child and adolescent theme if you'd like. Does it look different in the BIPOC community and in and among your neighbors, or has their lives, your experiences changed? You all came up, as youth in that same neighborhood. I'd be interested in any thoughts you have on it. But you also mentioned faith, and we're here at the Faith in Action Project. I know you both as friends, so I know faith is, this is your calling. Faith is a big part of your why, and you reference it. But faith is also part of the equation here. And does it have anything to do with reducing stigma or enhancing health?
Yeah, so I'll kind of touch base on the youth side of things first. And yes, youth are very important to us. We definitely serve a lot of youth. But oftentimes our stance, as well as if we're going to serve the youth and we're going to serve your child, we also need to be serving you as the parent. Because a lot of times it's easy for parents and adults to put their youth over here in therapy and say, fix them, they're having trouble, they're having issues. But oftentimes we have to look at the function of the behaviors, right? All behaviors have a function. What's causing this child to behave the way they are? And oftentimes it's the environment. So they can come to therapy, we can give them, coping skills and help them change their maladaptive thoughts. We have all these things, and then we send them right back into a toxic environment. And they're spending more time in that toxic environment than they are with us, right? So oftentimes we have to hit things at both levels. because the youth are important. And there's a lot of funds and a lot of dollars being invested in early childhood development and all those things. And don't get me wrong, we believe in it. We understand the importance of that 0 to 5 and all those things. But then we also have to look at it because it's multifaceted. We have to look at, are we talking about symptoms or are we talking about core issues? Because when we talk about symptoms, we're talking about directly dealing with the child and helping them overcome these barriers and these and new coping skills and all those things, right? Focused on the individual. And that's a lot of time what organizations and people want to focus on because it's easy to see outcomes, right? We can see that they're improving and they're having outcomes. But when we talk about core issues, I'm a social worker. My mind automatically goes to systemic, right? What are the things that's impacting these children to cause them to respond and behave in the ways that they are, right? Oftentimes we think about football players. I know a lot of athletes. Before they even take care of themselves, mentally, emotionally, what do they do first? They go back to their communities. They put dollars in organizations and try to eliminate barriers because the things that they came up through, they understand it, how it impacted them. So those are the things they try to change first before they even try to touch the individual sometimes. So we have to look at things from both layers. Again, the micro level, which is focused on the individual, and then the macro level. How do we impact policies, procedures, the funding streams, all these things to really have impact? Because again, a lot of our little ones in our youth, they're being born into learning how to survive, especially within our BIPOC communities, right? They literally are born not thriving, they're born trying to survive. We have mothers who are pregnant who are baking their kids in cortisol, who are living in high stress, tensioned areas, food deserts, high infant mortality rates, lack of health care access, right? All these things that constantly cause you to stress, right? High cortisol levels. They're in their trauma response all the time, even when they're sitting on the couch, right? And that's not safe. And the baby's baking in that. So when that baby comes out, guess what? They're born preconditioned with high anxiety levels and things of that nature because of, right? We talk about those types of things, and oftentimes research shows, and we talk about this often, is a lot of times when I was the homeless student liaison for a school district, I would get teachers often saying to me, this kid can't focus, they won't stay quiet, they won't sit in their seat, they're disruptive, they're doing all these things. And I'm like, if you knew this child's life and that they came to school with no running water and they didn't have food last night, they're sleeping on their friend's couch, all these things that they're enduring, they can't come to school and focus on math. That's the last thing on their mind, right? So how do we start taking care of those things that are impacting and the barriers in order to allow them to focus on school? And a lot of times we send them to the mental health organizations and they get diagnosed with ADHD and their own medication and all these things, and it starts sending them down this spiral, right? When really they're dealing with PTSD. I mean, like I literally in our community, I literally had a young man who was a part of a family whose relative got murdered. The next day he was in school. And this individual was close to him. But because of the lack of resources and access and child care and all those things, the only place for this child to be was in school. So he goes to school after seeing this, witnessing this, being a part of this, right? Lack of sleep, all of this, and now he's expected to go to school and do what? Right? Then he doesn't have the words to articulate his feelings and emotions, so the likelihood that he's going to behave negatively out of that is high. And then what's the response to that? Right? So again, oftentimes we have to then look, again, it goes back to that function of behavior. Are we saying it's an individual problem and we need to fix the individual? Or are we willing to look at the systemic issues and barriers that are impacting the people? Because the reality is we can put Band-Aids on symptoms all day because of the outcomes and what it says about our organizations and how it shows that we're having impact. But it's the core issues, the economic development, the lack of hope, all these things, right? These things that take time and development, right? It's those things that are going to start changing some of these things. When you start focusing on those things, you'll slowly start to see the symptoms decrease, right? Janelle, really quickly, if I may, Janelle often talks about how a lot of times it's a canary in the mine, which means when you're in the minefield and you're working and, sunlight or water or something gets through, that means there's compromise, right? And in our neighborhoods, when we're talking about high infant mortality rates, food deserts, all those things, it's telling us that there's a much bigger problem than these issues. And Kalen, you said you're a proud Indiana girl, and when you see something in Ohio, you're like, why don't we have that? That's often the same mentality that we have from a community level. When I'm in Southeast Fort Wayne and I'm seeing a lack of economic development and I'm seeing barriers and lack of access to healthcare and all those things, and I'm seeing development all around me in different areas of town, my thought process is often, why don't we have that? Right? Why do we have to drive 20, 30, 40 minutes to get access to things when other individuals don't? Why can't we have that same access right here in our community? Right? Which again, core issues start to nip at.
Right.
The
I thought you were
symptoms.
going to say Fort Wayne, Indianapolis, but that's a whole nother subject. No, thank you. Very, very powerful. And do you want to say a quick word about the faith factor first?
Huge believers. We are believers through and through. And oftentimes, many individuals, when we talk about our why, we know we were being obedient to what God has called us to. We know it's a call. Everything that we do, we know we're on assignment, and it's much bigger than us, right? But we also understand, so many people often ask us, are you a faith-based organization? Right? Because we serve anyone. We want you to walk through our doors no matter what your religion is, no matter what faith you believe in or whatnot, because it's our invitation to you to introduce you to God, right? No matter what your walk of life is. And we don't lead with that because we also understand that within our community there's been a lot of church hurt. There's been a lot of distrust of the hurt. The church is a part of that system that has created barriers and barriers over time. Be strong, have faith, all those things, right? You don't need mental, all the stigma. So we also understand that that can be a barrier. By us putting that on our website and somebody reads it, automatic turn off and no, right? It attracts a lot of people, but it also deters a lot of people. So we don't want that. Again, we don't want to be a part of that. But everything that we do in our facility, all of our therapists are believers. We have a prayer team, all those things. We don't announce it, but we have it. It's embedded within us. It's who we are. Our concept is we want to live sticky lives. So when you walk into our space, walk into our offices, you're going to feel it. You're going to feel it without us even saying it. And we introduce it to you. If you want to talk about it, we're going to talk about it. If you don't, okay. But allow me to fully be who I am and authentic in who I am, and I'm going to allow you to fully be who you are. And we're going to meet where we meet, and hopefully that's me introducing you to God by any way necessary. Because I may be the only Bible that they see that day or they read. So what am I saying to them?
That's awesome. I hope you'll go visit Courageous Healing in Southeast Fort Wayne because it is beautiful. Talk about sticky. I mean, it's just, you just want to stay there. I wanted to stay there. It's a beautiful space, and I know the aesthetic and the design elements were so intentional. And we want to give our best to our neighbors in those neighborhoods that oftentimes don't get the best. And that's what you built is amazing, physically as well as spiritually and socially. Can you tell us, Linda, a little bit more about
I think we don't have enough people trained to do the work. So even if it paid enough, that we would be able to see everyone that needed the services, we haven't invested for long enough in training the people. So that's one issue. We need more workforce development. And probably we have educated people for, too many, psychology, gosh, I went to school for 4 years of college, 4 years of med school, 2 years of, child fellowship, 3 years of residency. I mean, it's just ridiculous, the number of years it takes. And so that's probably excessive. We need some people with that level of training. We need a lot of other people with way less. So that's part of it. But I think the core issue is that if you open up a practice, or you're a hospital, or you're a mental health center, and you want to take private insurance or Medicaid, you won't even be able to keep the lights on. It just costs more than you get back in. I mean, our system, I work for IU Health, they invest millions and millions of dollars. We're like, yay, we only lost $2 million last year in our office. Good job, you guys. That's literally the conversations we have. And it's just because the supply and demand factors have impacted the salaries of the mental health clinicians in some cases in a good way, but now they cost so much that the reimbursement just doesn't cover it. So I think there have been signs, though, and that all has to do with stigma and understanding, right? Federally, the billing codes that we use, just haven't been recognized as being worthy of investing. It would cost a lot of money, billions and billions, right? Defense spending levels, right? Although I am glad to see that, like, we have all this money to help Ukraine. I was reading last, like, that's a good thing. But we need, it would cost a lot of money, but it would also have to be a major reorganization at the federal level within CMS, Center for, to make that happen. And the good thing is that in the last several years, they have been inching toward that. So for example, psychiatrists, I bill a code called the 99213 when I see a patient that comes back in. It pays a certain amount of money. It suddenly got way easier because of federal changes for me to bill a 99214 and a 99215, which pays me, my system, more money. They just did that overnight, and they're chipping away at it. But the impact of that was many billions of dollars across the nation. So it would be very hard for a politician to suddenly say, yeah, we're going to suddenly pay an adequate amount for mental health care, because that would cost an unbelievable amount of money and be a really politically challenging thing. So I have a feeling what will happen is it will just be chipped away gradually. And so maybe in 20 years we won't have this conversation, or maybe even 10. But there's just structural payment issues that make it just not feasible financially.
We're going to just take that as assignment. We do need to have adaptive systems. This is.
Well, Jay, not to interrupt, but I
ahead.
think with the roundtable and Lieutenant Governor, the first time you approached me about that, that was my hope. Like, that's why I'm there. And sometimes I think, I can't believe I'm in this room. Like, because I was like, I know I have a passion for this, and I love this, and yes, I have business experience, all those things. At the same time, like, I kind of felt like, I don't know what I'm bringing here other than, like, I know this isn't right. And talking to people like you, for you who don't know, Julie's also a recipient of one of our grants. And you're a perfect example. She was like, well, I'm getting part-time salary for doing a full-time job plus half this other person's job, and then I don't have the money to even hire this other person to run more programs, or I would because I have more people that need it. And we left that call and we're like, oh my God. And we almost doubled her budget from our gift. And like, to us, we were like, oh my God, we know, she was one of the first ones, and we're like, we know there's more people out here who, like, our gift would literally, like, the area that you are working in, or like the area you are working in, Aaron, like, 30 grand is gonna do, I mean, the things, yeah. And so, but anyway, my point being, like, that was, things like that is like what I hoped to affect, and I feel such promise with those meetings, and hope that there comes something from this many people at the table. And I think the promising thing to give you a little insight into those meetings is that most often it is commonly like comments like, we can't boil the ocean, or what are our achievable goals, and like, what can we actually show impact, and how can we actually get more diverse people on this round table. So it's not just us, talking to a few people, but hearing from as many people as we can to get a better collective idea from each of you who are making comments, and not just assume we know the best place to go, or and I think Jay Chaudhry will answer a lot about the funding that he has been, will be able to be dispersing, which will be great. But I was just gonna say, I feel some hope in the sense that as much as the pandemic was awful for so many reasons, there's this weird silver lining to it in this terms of mental health, in the sense that more people are struggling, but it's the first time that I feel a lot of people, for the first time, are ever experiencing a mental health anything, like whether that just be stress or any level of it. And I think that, you can understand something and relate to something when you have lived experience with it in some way. And I think that's a huge barrier in terms of trying to show why this is important. And I think, I'm hopeful that it's the first time I've seen our country talking about it in this way. And to me, it's like our family's always talked about it. So it's like one of those things where it's nice to almost feel like, oh, everyone, thinks this way, or hopefully cares about it. And even when we are doing any of our work, we've never had anyone tell us no. Like, everyone wants to, cares about this. And I think a lot of the responses are, we want to help you because we don't know we don't know what to do. Like, where should we be putting our money? Who should we be talking to? What are the right answers? And I think that's collectively, it sounds like everyone's just trying to figure that out. And I feel hopeful with people like this on the stage and with Lieutenant Governor and Governor's leadership that hopefully it will change for the better. And I always tell Leslie and the Lieutenant Governor, I'm not trying to be, I'm so passionate about Indiana and I love this state so much that when I see things like we're in the top 5 for worst states and how to handle a mental health crisis, suicide, depression, that's like, it's shocking, and it's how, and how are we in all of those? We're not just, so, it's not to say you're wrong or you're bad or, point a finger. It's how can we collectively realize we're all part of this problem, and unless we all work collectively as a cog, it's not going to go anywhere. And so I feel hopeful with conversations like these. So this was a great conversation.
Yes, it was. Thanks to you all. So join me in thanking them.
Thank you again so much for your time and your words. You've inspired us in many ways. At this time, we're going to break briefly for lunch. I encourage you to get your box lunch and drink, and you can go and enjoy your lunch where your breakout session is, which should be listed on your name tag. Your mic. So thank you again for the ways that you inspired us. At this time, we'll break for lunch. We invite you to grab a box lunch and a drink, and you can enjoy your lunch where your breakout session is, or if you're in Shelton, we encourage you to go to the cafe or the common room. Your breakout session is listed on your name tag. We also look forward to seeing you back for another wonderful panel, again, here in Shelton at 1:50. If you need anything, please let us know. And again, thank you for being here with us today.